Good evening, friends. Welcome to this Tuesday academic series from Yashoda Group of Hospitals and Department of Critical Care Medicine and ECMO. So today we are running that ECMO series, and today we thought of talking about the other side of the heart. Last week we spoke about the right heart failure and ECMO patients, and today Dr. Charan decided to actually take us through LV unload. The LV strain is not uncommon when we initiate patient with a VA ECMO, and the retrograde flow creates some amount of LV stress and stretch, which can probably disturb the LV maybe recovery or so. So we in India used to have many joggards, and some of them now started using also a more robust mechanisms. So to bring us through that topic, Dr. Charan will take us through the basics of LV unloading processes, which we generally practice across the globe and its importance. And to give us expert opinion, we have none other than Dr. K.R. Ramanathan, sir. He has been a favorite for many of us who has seen ECMO evolving over the last decade or so. And many of us listening to his lectures, listening to his sessions, we got inspired along with ESY and also society. He has been a director for the ECMO fellowships in National Institute in Singapore. Ramanathan, sir, it is an honor and privilege to have you on board. Thank you for joining us. We welcome you, sir.
A pleasure. Thank you. Thank you, Venkat.
Okay. So without wasting time, I request Dr. Charan to take us through the different indications, different ways we do LV unloading. How do we actually recognize a LV strain? And we will also debate on different either early LV unloading versus rescue, different mechanisms. How do we jugaad in India and all that? Over to you, Charan.
Thank you, sir. Thank you for the opportunity to actually speak about the LV unloading mechanisms or the what are the strategies of left ventricular unloading in patients who are on veno-arterial ECMO support. So we will be discussing about the LV unloading strategies here. Before we actually try to understand the LV unloading strategies, we have to understand what is the various what is the physiological changes which actually happen during veno-arterial ECMO for a cardiogenic shock. So the general consensus goes that veno-arterial ECMO helps all the other organs during cardiogenic shock except the heart. Probably it harms the heart more than it helps, but because it actually sort of takes the functions of the heart, we are essentially maintaining the organ functions before the heart has recovered. But directly speaking, veno-arterial ECMO does not probably help the heart. So what are the various changes that actually physiologically happening? What are the various changes which happen when the patient is on a veno-arterial ECMO? We can actually see that as time goes on, the right atrial pressures, because we are essentially bypassing the entire pulmonary circuit. We are draining the blood from the right atrium and giving it into the aorta. We can see that the right atrial pressures slowly come down. The pulmonary artery pressures and the pulmonary capillary wedge pressures slowly are increasing as time progresses on the patient on veno-arterial ECMO. The left atrial pressures are slowly increased, as well as the aortic pressures are slowly increased, where the mean arterial pressures per se increase, and as well as the aortic pressures. So the left ventricular end diastolic pressures slowly build up in patients who are having veno-arterial ECMO, essentially because of the increase in the LV afterload in patients who are having peripherally inserted veno-arterial ECMO. The peripheral insertion is the most common modality of initiation. It would be the femoral venous cannula with a femoral arterial cannula. So given these scenarios, we can actually understand what are the various pressure changes which happen across the myocardial chambers as well as in the lungs if the patient is instituted on a veno-arterial ECMO. So we are seeing increase in the LV afterload. Thus, we are actually seeing in the increase in the because of the increase in the LV afterload on an already failing LV, we can see that there might be increase in the LV left ventricular endostolic pressures. There is increase in the left atrial pressures. There is back pressure increase in the left pulmonary capillary wedge pressures, and there is a decrease in the right atrial pressures. So before we actually go into the concept of LV unloading, we need to understand these concepts of LV unloading are better understood if we are actually correlating with pressure volume loops. So to understand the normal pressure volume loop, we can actually see that in this particular slide, the left side, which shows left ventricular pressures on the y-axis, as well as the left ventricular volume on the x-axis. So the difference between, so the right lower point essentially determines the left ventricular end diastolic volume, whereas the left apical point is what determines the left ventricular end systolic volume. So the difference between the end systolic volume and the end diastolic volume will actually give us the stroke volume of the patient. And if you actually look at the line which is passing directly from the stroke volume, from the origin to that of the left ventricular to the end systolic volume, is the end systolic pressure volume relationship, the line. And then we have a non-linear curve called the end diastolic pressure volume relationship, which actually goes from the is a line passing through the end diastolic volumes. So based on this, we can actually make certain understand the various properties of the heart here. Whereas a line which is passing through the end from the linear line passing from the end diastolic volume, which crosses the end systolic pressure volume relationship through the end systolic volume, it actually gives us the measure of the afterload of the ventricle. Okay, so then as the stroke volume increases, this is the amount of work. So as much as the EDV minus ESV will give us the stroke volume, the total area of this curve is what gives the stroke work of this patient. And then the area which is between this ESPVR and EDPVR, which is bound by the stroke curve, is what is called the potential energy. So which is the energy of the myocardial muscle, which is not converted into active kinetic work. So PE plus stroke work, the amount of total work which is done by which is the total energy which is consumed by the myocardial muscle, is what is given by PVA, or the pressure volume area. So these findings or these particular concepts are very much important in understanding the dynamics of left ventricle during the normal function, during cardiogenic shock, and after the initiation of a ventricular assist device, especially ECMO or peripherally inserted or ventricular assist devices. So we can actually see that as much as the this particular graph is from the Heart Journal, it actually tells us in a patient in whom we have peripheral veno-arterial extracorporeal membrane oxygenation, as the amount of flow rates increase gradually, we can see that the LV the mean arterial pressure might come down, but at the same time the end diastolic volumes are slowly going to go up. So we can actually say that at various levels of ECMO flows, we can see that the stroke volume is slowly coming down. That is, the stroke volume is slowly coming down, the stroke work is slowly coming down, but at the same time, the curve is moving more towards the right. So if you are seeing that the curve is moving more towards the right, we are essentially seeing an increase in the pressure volume area. There might be decrease in the stroke work, but there is increase in the PE. So it is also causing total increase in the PVA in this scenario. The stroke volume is getting more and more narrow. There is no change in the end systolic pressure volume relationship relatively remains the same. However, you can see that there is gradual increase in the end diastolic volumes. So these are the changes which typically happen in an left ventricle after the initiation of a veno-arterial ECMO at sequential incremental flows. So what happens, or what are the various problems which we face if the patient is having significantly increased left ventricular end diastolic volumes or increased LV afterload? So essentially, we are talking about a failing heart, and increase in afterload of a failing heart is not going to help the heart in recovery in any way. There is increase in the left ventricular end diastolic volumes and pressures, which can cause increase in the left atrial pressure, so the patient might develop significant pulmonary edema. It also causes decrease in the left ventricular contractility. There might be a chance where your aortic valve won't open because of the increase in afterload, and the LV is unable to eject against the increased afterload, thus causing stasis of blood inside the left ventricle. And stasis of blood inside the left ventricle essentially can cause LV clot formation. So thus increase in the afterload and inability of the left ventricle to eject against this afterload, and the stasis of blood in the left ventricle is going to cause pulmonary edema, LV stasis, LV clot, and all this kind of things. Hence, it is imperative that at a certain stage, we will be discussing about the indication shortly. At a certain stage, this LV needs venting or unloading of the ventricle. So essentially, the LV is overloaded because of the veno-arterial ECMO and increased afterload, and this LV has to be unloaded. So what are the various unloading options we have? So this in order for us to unload, there is a chance that we might have to decrease the LV afterload or have to improve the LV contractility. or we can also unload by decreasing the LV preload. So these are the basic physiological criteria which we take into consideration for us to effectively unload the left ventricle. Now, what are the various indications of left ventricular unloading? These indications include, there are like hemodynamic parameters, there are echocardiographic parameters, and there are clinical parameters. The hemodynamic parameters include as we've discussed, increase in the PCWP, the pulmonary capillary wedge pressures of greater than 18 millimeters of mercury, essentially signifying that this patient is having increased left atrial pressures. Then there is lack of arterial line pulsatility, where the pulse pressure is less than 15 or less than 10 millimeters of mercury. The echocardiographic criteria includes increasing left ventricular dimensions. If there is stasis of blood within the left ventricular cavity, there is LV thrombus. If we don't see an aortic valve opening in the echocardiograph, or if there is left ventricular outflow tract VTA, LVOT VTA is less than 10 centimeters. The clinical parameters include development of a pulmonary edema or a refractory ventricular arrhythmias, probably because of the dilatation of the LV. So if these hemodynamic or echocardiographic or clinical criteria are met, then we have to actively start thinking about LV unloading and what are the various methodologies for us to effectively unload the LV. Okay, so we have actually seen what are the indications of LV unloading and what are the various types of LV unloading. So there are a lot of types of LV unloading, which includes broadly can be categorized into two strategies, namely active venting strategies and passive venting strategies. The active venting strategies are the ones where we actively drain the blood, we suck the blood out of the LA or the LV. Whereas passive venting strategy is that we make rent and we are expecting the blood to follow the pressure changes and flow into the less pressure chambers of the heart. So what are the active venting strategies we know? The active venting strategies are the pulmonary artery drainage. So this is a relatively newer modality which is coming called the PA VA ECMO, where pulmonary artery drainage is done. So pulmonary artery drainage can be done with percutaneous techniques or with surgical cannulation directly of the PA, and this blood is or this limb or whatever we are actually draining from the pulmonary artery is directly connected to the venous drainage cannula of the ECMO, thus actively draining the blood from the pulmonary artery. It can be either percutaneous initiation or surgical initiation. So that is called, it's an active pulmonary artery drainage strategies. Similarly, from pulmonary artery, we can go from the left atrial drainage. So it can be a percutaneous technique with a transseptal cannulation of a single stage or a multi-stage cannula called which we will be seeing a little bit later, or it can be a surgical cannulation. Surgical cannulation, it can be the left atrium can be accessed through a right superior pulmonary vein. So then comes the left ventricular drainage. The left ventricular drainage also has a percutaneous or a surgical technique. Surgical techniques is something which we have a transapical catheter insertion into the left ventricle. And if it is percutaneous drainage, which can also be occurred with some catheter drainage or a pictal catheter, trans-aortic pictal drainage of the LV can be done, which is a relatively old method. And now we have continuous non-pulsatile percutaneously placeable VADs called Impella devices, which can be directly used for left ventricular drainage. However, active ventage dialysis, other venting strategies can be IABP, or the passive venting strategies, especially atrial, is a septostomy, which can be done with stent implantation or balloon septostomy or a blade septostomy. So where if we are just making a rent in the interatrial septum, thus allowing the blood to flow from the left atrium into the right atrium. So we are essentially creating a left to right shunt, where the amount of blood flow from the left atrium to the right atrium cannot be controlled. It just follows the pressure curve. So hence these are called the passive venting strategies. The other passive venting strategy is to come down on the ECMO flows, which can decrease the afterload. But at the same time, we have to also make it a point that we are supporting the patient appropriately by giving adequate ECMO flows so as to have good systemic perfusion. So this is one of the pictorial representation of what are the various kinds of venting strategies we know. There is a surgical direct thrust strategies called the transmitral or a transventricular apex catheter directly inserted into the left ventricle. There is a LA strategies. So LA strategies can be a surgical strategy with a like pulmonary vein or through a interatrial septum. Then we have percutaneous direct strategies like Impella directly into the LV. Indirect is atrial septostomy. Okay, so we can also cannulate the pulmonary artery either by surgical methods or percutaneous methods. This is just the pictorial representation of what are the various strategies which we were discussing in the previous slide. So the first thing, whenever we have a patient who has increased LV afterload and the LV is dilating with aortic valve is not opening with LVOT VTI of less than 10 centimeters, then it's imperative that we start with the lesser invasive first and go into the more invasive ones. So we can actually see that the first thing what we can try is to increase the increase the inotropic agents. So initiate inotropic agents and increase the dose of inotropic agents. What do they essentially do? They do is that they increase the contractility of the ventricle. They are inodilators, especially milrinone, levosimendan, and dobutamine. They also decrease the afterload. So by decreasing the afterload and improving the contractility, we are seeing that this there is ejection of the left blood inside the left ventricle into the aorta, essentially causing more aortic valve opening. So it enhances aortic valve opening. Because it decreases the afterload and improves the contractility, we are actually looking at an increase in the stroke volume. So we can actually see that in this particular pressure volume curve, we can see that the contractility increases. You can see that the ESPVR has gone up. The end diastolic volume has come down a bit. So it is able to eject better by virtue of its increase in contractility. You can see that the stroke volume has improved because end systolic volumes have come down. End diastolic volumes have also relatively come down, but you can see that there is improvement in the stroke volume. However, because of the increase in the contractility and increase in the stroke volume, we can see that the PVR of this particular scenario increases. The pressure volume area, PVA, the pressure volume area in the pressure volume loop by using inotropes is increased. So pressure volume area is the total work which is done by the myocardium, and hence it is directly proportional to the myocardial oxygen demand. So essentially speaking, inotropes, even though they improve the stroke volume, even though they decrease the afterload, they cause increase in myocardial oxygen demand, and it causes increase in the stroke work as well as in the increase in the potential energy of the myocardium. Then comes intra-aortic balloon pulsations. So the most commonly used LV venting strategies are being discussed. So next comes the intra-aortic balloon pulsations. So intra-aortic balloon pulsations, as we know, it decreases the afterload. It decreases the afterload. I'm sorry for this one. So it decreases the afterload. It improves the diastolic pressures. By improving the diastolic pressures, especially in a patient with acute coronary syndrome, it improves the coronary blood flow. However, the studies have found that it causes minimal unloading. In fact, there is a meta-analysis in almost 1,500 patients which has said that IABP along with ECMO is not going to improve the outcomes in these patients. You can actually see that the patient is having in a patient who is having a cardiogenic shock, he has got very significantly high end diastolic volumes, lesser contractility. So this in patients who are initiated on ECMO with the patient who is having cardiogenic shock, the stroke volume has significantly come down, the end diastolic volumes have come up. So at the same time, by initiating ECMO and IABP in these patients, we can see that there is a decrease in the end diastolic volumes. There is not much change in the stroke volume. There is no change in the contractility of the ventricle. However, it is also causing decrease in the PV area, thus decreasing the overall myocardial oxygen demand in these patients. However, the changes which we see are relatively less, means they are not as good as expected for a patient if we are initiating IABP and VA ECMO in these patients. However, it can help. We can actually see that there is decrease in end diastolic volumes and also there is total decrease in the pressure volume area in these patients. Now coming to the atrial septostomy, the next comes which requires a cath lab initiation. So atrial septostomy is essentially going from the femoral veins into the right atrium, do a blade septostomy or a balloon septostomy. It is a passive unloading technique where we are essentially creating a left to right shunt and we are unloading the left atrium. However, atrial septostomy is much more studied and more used in pediatric populations. Its use in adult is not as studied as much. It causes significant decrease in the LV preload. So thus, by redirecting the blood from the LA into the RA, we are essentially decreasing the significant amount in LV preload. However, it does not cause any change in the LV contractility. There is not much change in the afterload when it really comes to with an atrial septostomy. You can see that with the help of with an atrial septostomy, the end diastolic volumes have come down significantly. Because the end diastolic volumes have come down significantly, you can also see that there is decrease in the stroke volume. So when compared to that of a cardiogenic shock, ECMO itself causes decrease in the stroke volume. However, ECMO plus atrial septostomy has caused a significant decrease in the stroke volume And because there is significant decrease in the stroke volume and we are essentially coming down on LV preload significantly less, LV sometimes can hardly eject. So if the ejection of which is by the LV is not up to the mark, we are essentially causing the blood to be inside the left ventricle because the aortic valve might not open because of very less stroke volumes and very less pressures which are generated by the LV. Aortic valve might not open. So there is risk of decreased aortic valve opening, and there might be a chance where we can see that there is LV blood stasis in the LV, as well as some blood clot which can be formed in the LV thrombus, or LV thrombus formations can occur. It decreases the overall, decreases the stroke work, no doubt, decreases the PE, it causes decrease in the pressure volume area. So the myocardial oxygen demand comes down, but at the same time, by decreasing the stroke volume to a reasonably high extent, it carries a risk of LV not ejecting blood, aortic valve not opening, and LV thrombus which might happen. Coming to surgical LV venting, the surgical LV venting is a direct transapical cannula placement in the LV. So by causing significant unloading in left by surgical LV venting, a similar scenario which we have seen in atrial septostomy might happen, where the aortic valve might not open. However, even if aortic valve might not open because we are directly decompressing the LV here, the chances of blood stasis in the LV and blood clots which can form in the LV are relatively less. However, because the aortic valve also does not open, we can sometimes see the stasis of blood near the aortic root, and there might be aortic root thrombus which can happen in patients who are having surgical LV venting. And we should also understand, because we are placing a surgical transapical placement of an LV vent, we are essentially compromising the quality of the left ventricular apex. Sorry. So there is significant decrease in the end diastolic volumes, not much change in the contractility. However, it has maintenance of the some stroke volume is actually maintained in case of LV venting. Coming to percutaneously placed ventricular assist devices, especially the like microaxial flow pumps, the non-pulsatile microaxial flow pumps, transaortic. So the best methods of the best example of upon a peripherally placed ventricular assist device is a Impella. Sometimes tandem heart can also be used, but tandem heart is something which actually involves a intraatrial septal placement of a cannula and draining blood from both the LA and RA and giving back into the aorta. So, however, that modality much more correlates with that of the active left atrial unloading. But when we are looking at peripherally placed ventricular assist device, we are actually looking at Impella. So Impella is placed, which is placed percutaneously via the aortic valve into the LV, where it sucks the blood out from the LV and pushes into the aorta. And it actually causes a direct unloading of the left ventricle. However, the advantage here is that it adds to the cardiac output. So we are not essentially draining the blood from the LV into the drainage stream of the ECMO and giving back into the aorta, but the actual blood in the LV is pushed into the aorta. So the amount of the Impella can actually add on to the cardiac output of whatever we are giving through ECMO support. So we can definitely see that there is a significant decrease in the left ventricular end diastolic volumes. Obviously not much change in the contractility. The stroke work can come down. The PE comes down very significantly. The total amount of pressure volume area with the Impella device is very less when compared to that of ECMO, as well as to that of an IABP on ECMO, etc., and other modes of LV venting. We can also, but what we have to remember, or what is the special consideration when we are talking about Impella and ECMO, or ECPella as they call it, is that it can cause what is known as Harlequin syndrome. Harlequin syndrome is sometimes what we see in a VA ECMO patient who has got bad lungs. When the myocardium is improving, the LV receives blood from the pulmonary circulation which is not oxygenated, and this deoxygenated blood can be ejected out into the aorta, and the brain and the upper half of the body can receive deoxygenated blood, which we see in VA ECMO with ARDS patients when it is placed on a peripherally placed veno-arterial ECMO, especially the femorofemoral ECMO configuration. However, in case of an Impella, if at all the flow rates between the Impella and the ECMO are not regulated tightly, sometimes what happens is Impella can actually drain a lot of blood from the pulmonary circulation, because if it is placed at higher flow rates, and thus it is causing more amount of deoxygenated blood from the pulmonary circulation to be ejected out into the aorta, with an Impella if the patient is having concomitant ARDS or concomitant pulmonary edema or pulmonary disease per se. So in patients who are on Impella, if the Impella flow rates are more than what is required, they can actually drain the blood from the pulmonary circulation, like from the pulmonary veins, which are deoxygenated because the patient is having bad lung function. And this deoxygenated blood can be ejected out into the aorta, thus causing an harlequin-like syndrome. So in which case we have to come down on the Impella flows. And the advantage of having an Impella, like especially with Impella CP or Impella 5.5, is that we can actually wean the ECMO part in ECMO and then slowly transition the patient from VA ECMO onto Impella. So and then the patient can be on Impella for longer than usual, because we know that in patients with acute coronary syndrome and AMI-CS, Impella is having better survival benefits than VA ECMO, as proven by the danger shock trial. And we know that the ECMO in patients with AMI-CS alone does not have good survival benefit as per ECLS shock trial or the ECMO-CS trials. So putting everything together, so if we are actually superimposing all these pressure volume loops one another, we can actually understand what is the better modality or what is the best modality of LV unloading. We can actually see that the blue curve is the VA ECMO. And if you actually place up LVAD with Impella with VA ECMO, we can see that there is significant decrease in the end diastolic volumes. There is significantly decrease in the area of the stroke work. There is decrease in the pressure volume area. And we can see there is not much change in the contractility. And thus, this is the one which can actually, in acute myocardial AMI-CS, or especially patients who are having acute coronary syndrome and who are requiring ECMO supports, we can see that this actually decreases the myocardial oxygen demand significantly. However, IABP can also, especially in Indian scenario, we are forced to, we cannot think of Impella as the primary modality of LV unloading because of its cost constraints. However, IABP provides if not as good, at least some amount of LV unloading can be achieved through intra-aortic balloon pulsations. Inotropes are the primary or the first line therapy if the patient is going into significant cardiogenic shock, if the patient has gone into LV distension on a patient with VA ECMO. So almost all the patients will be started on inotropes first. But the thing is, we have to also remember that they are essentially increasing the pressure volume area, thus increasing the myocardial oxygen demand. So we cannot use inotropes beyond a point, and or else we are essentially harming the heart here. So what are the various unloading strategies here? So we know that the inotropes or the vasodilators are simple to implement, but they have a limited LV unloading. IABP is probably the best bedside implementation modality which is available, especially in Indian scenario, but it has an unreliable degree of unloading. If at all we are looking for cath lab related procedures where we can do a balloon atrial septostomy or atrial septostomy and putting a cannula into the LA, thus draining the active LA draining, it is possible, but balloon atrial septostomy is an indirect LV unloading. We cannot have any control over the amount of blood that can be unloaded. And the patient might be having residual like ASD even after decannulation. And even though the guidelines are unclear whether or not to close this ASD after the patient has recovered. Surgical LV venting is a reasonably better direct LV venting, but it provides actually a reliable LV unloading. But however, it is a surgically placement. It impacts the apex of the heart. There is blood stasis around the base of the aorta which can happen. Percutaneous LV venting, similar, but it is not it's a direct LV unloading, but we need to place a pigtail catheter, direct transaortic pigtail catheter placement into the LV and drain the blood and the blood is drained, and it has to be connected to the drainage part of the circuit of the ECMO. So it does not actually provide extensive LV venting, but it is limited it is limited by the size of the pigtail catheter what we are using to vent this. There is blood stasis which can happen in the proximal aorta also. So percutaneous ventricular support, Impella or ECPella, it is something which can actually provide reasonably good LV venting. And we should be careful about the harlequin syndrome, which can happen if we are venting with an Impella. However, we should also the troubleshooting part of that is that we should be coming down on the flows of the Impella if at all the patient is developing north-south syndrome. And we also have to remember the fact that Impella is associated with increased platelet consumption and increased bleeding related complications, but that is something which we have to balance against the risks. Central VA ECMO, it can provide adequate LV, like even then, because this is most commonly used in post-cardiotomy patients who require veno arterial ECMO support, and even in these patients, it requires a surgical placement of the of an LV vent, preferably through the pulmonary veins into the LA. So based on this is actually a slide from the ELSO guidelines on the management of veno arterial ECMO patients. So we can actually say that if there is significantly almost pulseless with the CVP greater than 20 with no aortic valve, LV's distension is severe. With we can actually see that spontaneous echogenic contrast is available seen in the LV with IVC dilatation and anything. We have to go for invasive catheter-based techniques. So this is actually one of the guides which can actually help us to understand the degree of weakness, the degree of LV venting required, and what are the maneuvers. So like less invasive maneuvers or more invasive maneuvers are used, which have to be used for LV venting in these patients. So there are certain novel methods which have come up recently. This includes the NAVA ECMO and the PAVA ECMO. So the LAVA ECMO includes placement of a cannula into the left through the interatrial septum. So it's a transeptal approach through the interatrial septums into the left atrium also. So we drain the blood essentially from the left atrium, from the right atrium also, and this blood is drained and we are giving the blood back into the aorta. So it's a LAVA ECMO, so left atrial veno arterial ECMO. So it can be done with the help of a single cannula, which is multi-stage. So we can actually see in this picture that it has a stage, some cannula related orifices are present in the LA, some are present in the RA, and some are also present in the IVC. So it's a multi-stage cannula, and these multi-stage cannula can be inserted, and one stage is in the LA, one stage in the RA, one stage in the IVC, and we drain the blood from all the three aspects and then give the blood and then return the blood back into the artery. So this is called the LAVA ECMO, which has this inherent modality of it vents, LV venting, because it essentially empties the left atrium here. So it can also be done with a two-stage cannula, where we drain the blood from the RA independently, and then we do a transeptal puncture and put a cannula into the LA. So we drain the blood from the LA, we drain the blood from the RA, and return the blood back into the aorta. So this is also a two cannula technique where we can initiate a LAVA ECMO. Coming to the PAVA ECMO. So this is like if at all we are draining the pulmonary artery. So this can be a percutaneously placed pulmonary arterial ECMO, or it can be a surgically placed pulmonary arterial ECMO, where we are draining the blood essentially from the RA, and we are also draining the blood essentially from the PA, thus reducing the LA preload, and thus reducing the blood flow to the LA and decreasing the LV preload. So adequate drainage of this pulmonary artery can also provide us with a reasonably good LV venting, or it prevents LV dilatation. I'm actually using venting with unloading quite interchangeably. Those should be ideally considered as a different these things. So this is if you are actually placing a pulmonary artery, it is a LV unloading technique where we are decreasing the LA pulmonary arterial blood flow into the LA, and also we are also reducing the LV preload. So thus by decreasing the LV preload, we are preventing the LV dilatation. So this is essentially an LV unloading technique. So it can be done with the percutaneous technique or a surgical technique. So percutaneous technique includes putting a PA catheter, placing a guide wire through the PA catheter, and reloading the cannula on that. It can be done with the protective cannula, or it can be done with any venous cannula, but it has to be placed in the PA adequately, and it is draining the blood from the PA. Or the surgical technique includes directly placing cannula into the pulmonary artery. So by draining the blood both from the pulmonary artery and the right atrium, we are essentially decreasing the LV preload. So that is what the ideal mechanism of action of this novel methods. So to actually summarize, how do we decide on the patients when to unload the LV, and based on this, what are the various effects? So when we have unloaded the LV, then we have to look at the signs of LV improvement, where if your velocity time integral is greater than 10, if you are actually seeing there is improvement in the pulse pressure to greater than 10 millimeters of mercury, 10 to 15 millimeters of mercury, and then if there is an improvement in ejection fraction to greater than 35%, then essentially your myocardium has been recovering, and at this time we should be actually thinking about the removing of the LV vent. So whether or not to remove the LV vent during the ECMO decannulation, or we remove the LV vent first and then allow the LV to be we remove the LV vent first and then leave the patient on VA ECMO for a while and then decannulate subsequently on VA ECMO is a matter of debate. However, if the patient is supported on a VA ECMO, we have to first initially titrate the flows of the ECMO so much so that we are essentially perfusing the organs properly. That is, the mixed venous saturation should be greater than 70 and lactate should be less than 2. And then we are looking for clinical complications or echocardiographic criteria. So if the clinical complications include pulmonary edema, refractory ventricular arrhythmias, or echocardiographic complications where aortic valve is not opening, second the LV and all, and if LVOT VTI less than 10, etc. If these are the things, if you know that the pulmonary capillary wedge pressures are greater than 18 or the patient is developing significant edema, we can first titrate the inotropes and optimize fluid status. And if we are able to get away with that, we are lucky. If at all we are not, then we have to go for LV unloading strategies. So after initiating the LV unloading strategies, depending upon whatever is our preferred method, after the recovery of the myocardium, we can actually look for de-escalation of the LV venting supports as well as the VA ECMO supports. Thank you.
Thank you, Charan, for that overview. I think you tried to bring everything in and out of that. Ramnathan sir, do you want to give an overview, or we'll take some questions, then we will get anything?
Yeah, one or two comments here and there, Venkat. Well, at the outset, I think the fundamental concept here is VA ECMO is not deleterious to the heart all the time. It's actually, if you look at it, the configuration wise, it's RV protective, but it loads the LV. So clearly, that is where most of the problems come when LV tends to recover. So if you consider the heart as a whole, it's in fact very friendly to the RV, but it is actually deleterious for the LV, and that's where this talk on LV unloading becomes very important. The second point I'd like to bring up, it's actually quite debatable, given that VA ECMO is unphysiological to the LV, whether unloading should go hand in hand, because there are observational studies to say that unloading helps, and clearly unloading aids myocardial recovery. And in that context, having or running a patient on VA ECMO hand in hand with an LV unloading strategy, is that something which should be routinely used or selectively used? It's always a gray area or a controversy in the ECMO literature currently. We'll soon get answers to that. But yeah, having said that, that's an important point to think about. And last point, which again I'd like to highlight, Sricharan showed that wonderful slide where LV unloading was indicated. I would rather rephrase that slide as absolute indications for LV unloading, because those conditions which Sricharan listed there essentially would need LV unloading at all costs. There's no way that you can get out of that situation without unloading. However, if you look at LV unloading strategies as a whole, most of the time we indirectly unload LV by using an IABP along with ECMO. And if you look at the strategies that have been used for LV unloading during peripheral VA ECMO, we did a nice network meta-analysis looking at about 50,000 patients who had almost all combinations of mechanical cardiac support devices. And we figured out that, quite similar to what the ECLS shock trial showed, ECMO in unison doesn't help the LV. But if you use ECMO with IABP, it definitely helps. The number needed to treat is about 8. The same thing happens with ECMO and LV unloading with Impella as well. Quite similar numbers. So as much as the LV goes, the use of unloading strategies has to be thought about even when the patient goes on VA ECMO. One of the common mistakes we do in clinical practice is when the patient goes into stage C shock, we start inotropes. Most of the time, our inotropes, many of the time I've noticed that at least in my setup, the first preferred inotrope for some reason, even in cardiac failure, is NORAD, and some people even start vasopressin. And these are pure pressors that can worsen your heart failure in that setting. So you end up going on ECMO just to swap inotropes, and then you start them back on a pure inodilator or an inotrope. You find that things change quite dramatically. So I think a lot of this management should happen early with judicious use of the right trope rather than the pressor, and then you escalate it based on what stage of shock your patient is in. Thanks, Venkat.
So, sir, you brought some interesting areas of debate. You said, is it flatline when you have a VA ECMO in place? You should have a process of LV unloading versus absolute indication, which Dr. Charan said. You are rephrasing that, where you have no escape, but you do a unloading. So I think we do see some of our patients who do get treated without a proper LV unloading. And again, when we are talking about LV unloading, other than IABP, all the other procedures, either they were massively invasive or they are cost burdening. You talk about Impella 5 or whatever 3.5, it adds a huge amount of cost. And that is one of the reason why we actually, again, when we have to go back to the family or the insurance provider to actually talk about the add out that. So how do you actually place them? See, one is you said the selecting patient, which category needs, and you said absolute indications are clear that you need an unloading. And once you decided you need an unloading, at least that category to start with, how do you identify which are the criterias you take? Most of the slides which Charan said are a PA catheter based, pressure based, and most of us don't use a PA catheter in most of these instances. So what are the other modalities you use to find out?
Yeah, I think that's, you've asked two main important questions, Venkat. I'll answer the first question because that's easier done. How do you choose what mechanical cardiac support device when you are offered or when you have a patient in cardiogenic shock? I think that aspect is easily answered because over the period of years, with the SKY classification becoming more popular, one thing that has happened is we have used the SKY classification to stratify cardiogenic shock to the point that we now discuss on which stage MCS devices should be inserted. So once your patient reaches SKY C, late SKY C or early stage D, and the patient invariably needs a mechanical cardiac support device. I think that aspect is becoming more and more clearer. The second aspect that also needs to be considered along with here is the way cardiogenic shock is managed nowadays, especially in the context of AMI. It's not just, balloon to dilatation time that's important now. There is an onus on balloon to unloading time as well, because cardiologists are now realizing that they're doing a beautiful job with their PCI in the cath lab, but they're losing patients to multi-organ failure in ICU. So one thing that has come up in the recent 4 or 5 years is any patient with cardiogenic shock who goes to the cath lab gets a right heart cath done straight away. And there are two values they look for. One is what is called as the cardiac power output, which is an indirect measure of LV function. The other one is a pulmonary artery pulsatility index, or PAPI, which is a measure of right ventricular function. And based on which one is deranged, you choose your device appropriately. So RV dysfunction, VA ECMO might work. If it's a pure isolated LV dysfunction, Impella might be the best. So, and that's where, you can very well justify why danger shock trial showed survival benefits and ACLS shock trial didn't show it. So that aspect is more or less clear as to the choice of MCS device. Now, coming to the second question, should we be using PA catheters regularly? I mean, to me, I think PA catheters are making a comeback to ICU after a long time. And I think this is a welcome sign because there's a lot of logic and science applied to the use of PA catheter now, especially with advanced cardiogenic shock. It does help you not just know the progression of shock, but also it helps you with the various devices. So if we were to change the way we are managing cardiogenic shock, at least patients who have stage C cardiogenic shock should have a PA catheter inserted and managed appropriately thereafter. Now the question comes whether, I don't believe in PA catheter, or I don't have a system where we can routinely use PA catheter. Can we replace it with an echocardiogram? You need the technical finesse to interpret an echocardiogram in this context and to calculate the wedge pressures and other things using the echo. So clearly, from a cardiac intensivist perspective, or even from an intensivist perspective, we are trained only in POCUS, which means limited aspects of ultrasound, we know how to do it. Advanced aspects, we may or may not be able to do it, or we may be interpreting them wrong. So that we got to be careful if you are going to replace echo with PA catheter. To me, I don't think echo can replace PA catheter on any date. It gives more succinct values compared to the echocardiogram. It may give you some of the values on echocardiogram might be useful. One of them would be aortic VTI. So when a patient goes on ECMO and you continue to serially measure aortic VTI, one of the things, again, these are all based on observational studies and small case series where people have looked at various yardsticks. A serial reduction in aortic VTI as and when the ECMO run happens might be an indicator to the fact that LV is dilating or the LV is unable to eject better. The other parameters would be the LV diameters, which will be progressively be increasing. Now, if you ask me, is there a cutoff beyond which I use invasive LV venting? I don't have a cutoff as of now, but I would think an aortic VTI of less than 6 or gradually enlarging LV.
Dimensions.
Yeah.
Some of the questions are related to the dimensions of indication for LV venting. Yes.
So that essentially would make would point out to the time where LV venting is absolutely needed. So for now, I think we are all embarking on the track that we will insert an invasive LV vent only when it is absolutely needed. When people around us are already talking about prophylactic LV venting on VA ECMO. So clearly, world around us is clearly talking about it. They have not reached any consensus, but I'm just saying that,
It's trending towards that.
Yes. So that's something, which we need to think about. We need to be proactive than be reactive in this scenario.
Similar question. Ideally, LV unloading needs to be done within a couple of hours of initiating of a VA ECMO, then a reacting unloading.
Yep.
Or sometimes the same question, prophylactic versus a rescue unloading.
Yes, exactly. So that is exactly. So I think, at one
the
point,
questions are same.
ECMO in a similar scenario, whether to use ECMO in a rescue scenario. Now I think we have matured to the point that we now use ECMO left, right, top, bottom. Yes. And now we're talking about the next stage, unloading the LV in a rescue pattern or unloading it preemptively. Clearly, I believe in unloading it preemptively. Okay. But you may have people arguing against it as well.
Okay. Now, coming to the different types which we use right now in India, you very well pointed out that the initial choice of inotropes been vasopressin or an noradrenaline. And the reason I think most of our intensivists prefer them in the stage is, as you said, because of the MAP or pressures being pretty low. So they want some pressure to be built by squeezing the vessels to maintain some perfusion at the target. Whereas they believe that if I start a inodilator, something like dobutamine or levosimendan or amilerinon, I may further lose the pressures, the MAP to perfuse my organs. I may have some help to my heart, but I may lose. So how do you balance? Suppose it's been a conventional teaching that when your MAP is below 60 or below 50, you put some vasopressors, build up the BP up to some amount, then you add an inodilator. What do you do, Dr. Ramnath?
Yeah, so there are two things here. Use of an inodilator, say dobutamine, milrinone, or levosimendan, usually goes hand in hand with a vasopressor, say NORAD. Very often, you will have to mix and match the dose of each in such a way that one does not, or the inotropy does not, or the the vasodilatation does not overshoot. So you'll have to keep it in check using a vasopressor. What I do in my practice is I don't introduce dobutamine or milrinone much early in the stage of acute heart failure. I rely on an age-old drug, adrenaline, and sometimes it can be tricky when the myocardium is irritable and it's arrhythmogenic. Adrenaline can be tricky, but about 70 to 80% of the time it works, and it's got good inotropic features with less pressor activity. And if at all, there is an enhanced pressor activity or sympathetic activity, I tend to use a small dose of GTN. So what I tend to do is, with milrinone, dobutamine, and levosimendan, they have two components. There's an inotropic component and a vasodilatation component. Now, the issue with these drugs is it's very much dose related, and the amount of inotropy versus vasodilatation per patient is quite variable. So the amount of vasodilatation and inotropy for a particular dose of milrinone will be different for patient A versus patient B versus patient C. But in the same patient, if I were to use adrenaline and then titrate my vasodilatory component with a slight dose of GTN, I can modulate inotropy separately and vasodilatation separately.
Okay.
And this I tend to do in the acute stage of heart failure. And once they're more stable with it, then you introduce dobutamine or milrinone, then it's okay. I think they just get better thereafter.
Interesting. I think some hesitation because of its arrhythmogenicity keep us away, but I think it makes some logical sense that you want some amount of inotropy, some amount of vasopressors, squeezing the vessels all together in the same agent. Adrenaline scores over both of them without inodilatory. So that's where you use, but you carry some amount of arrhythmogenicity, which you take a risk at that point of time where you have a C or D.
So if the patient gets into, say, severe tachycardia or arrhythmia, I do have to change my strategy at that point. So I just cannot rely on this combination to work. I'll just have to abandon it or use something else. I mean, even dobutamine would cause tachycardia in this scenario.
That's another question somebody posted. Tachycardia due to adria and NTG. How you manage it?
Yeah, so if that were to be the case, I mean, up to a certain extent, I would accept it, say a heart rate up to 110. Yeah, I'm okay with it. But, if it still goes into severe tachycardia, then it becomes very tricky. You end up using other inotropes. You might go back to NORAD again, or you might even end up using milrinone in such a situation. But, to me,
there's no perfect answer at this point of time. You play around. Tachyphylaxis with NTG, do you find it common? There's another point.
It is common. Beyond a certain stage, it is very tachyphylactic. So, and that's where, by that time, I hope that the heart has recovered enough to get converted to either milrinone or dobutamine, which becomes easier to manage then.
The other points here is you spoke about very specific subset of acute myocardial infarction leading to cardiogenic shock, LV predominant, giving an Impella solves your problem. You put it in a cath lab, shift the patient, couple of days of support, probably they get better and they come out. But what about other forms? When you see a myocarditis, you see stress cardiomyopathy, we see a dengue myocarditis, autoimmune myocarditis. We don't know sometimes why my myocardium has suddenly failed and EF is 10%. What do you do in those situations?
So if after the danger shock trial, I think a few things that have become very clear is that the use of VA ECMO in cardiogenic shock has limited indications. So biventricular failure is one good indication. Ventricular failure left ventricular failure with acute respiratory failure would be another indication. The third indication would be recurrent unstable arrhythmias. And of course, the last but not the least, cardiac arrest. So these four scenarios are definitive indications for VA ECMO in cardiogenic shock. Isolated LV dysfunction, the first choice.
Impella.
Yeah, I mean, even though I say we do the right heart cath, the first choice of MCS device still remains IABP, and we go on Impella only if IABP is not working. So we do wait or give the patient a chance on IABP before we insert Impella.
And this is about not myocardial infarction cases across all the spectrum with only left ventricular failure.
Yeah, that's an important point. So you get to see mainly this in acute AMICS, so acute MI cardiogenic shock. In non-MI cardiogenic shock, it's more of a global presentation. It's more of biventricular failure, and I feel ECMO definitely would have a role there. In fact, our last 4 ECMOs have been for patients with dilated cardiomyopathy who have biventricular failure. So they just, it follows the same kind of criteria as we normally use for VA ECMO. So the role of VA ECMO in NMICS, that is non-myocardial infarction cardiogenic shock, I think it still has a role because of its presentation, especially with biventricular failure.
How you choose your LV venting in all of them? We're talking about non-myocardial infarction, biventricular failure, and you needed a VA ECMO. If you go to that subset, Impella is a clear in a myocardial setup, infarction setup, but rest all, how you will choose?
Yeah.
So very interesting point. Even in India, most of our cardiac colleagues, even though they understand we have a lack of literature evidence supporting IABP's role, but that still remains one of the earlier modality to support. And if it fails, or somebody who has been preemptively ready for an Impella, they go. Otherwise, it's not easy to convince a family on table to actually switching to an Impella. So IABP still remains, and we don't know. The data need to be probably reevaluated in Indian scenarios. How many of them do make better, or how many of them we do? But it is a standard practice there itself. You said, and LV dysfunction, IABP remains the first choice. Not working, switch to Impella. That's what you are saying.
Yeah. So the argument for that, I mean, I'll just make a simple argument. Now, IABP went out of vogue because of 2 shock trials.
Yes.
And those 2 RCTs essentially looked at 28-day mortality. So any patient who gets a MI and an IABP at 28 days, whether they survive or not. My question here is, my patient is dying right under my nose. If he can survive the next 3 hours, I can at least switch him over to the next MCS device. So I use IABP in this context as a bridge to the next MCS device. Clearly, these RCTs have not looked at the impact of IABP in that short interval. So clearly, we are interpreting RCTs wrongly, if you ask me, and we are just extrapolating what was found at 28 days to what is happening within 2 to 3 hours. You have used IABP quite a lot, Venkat. You clearly know how patients come out of this shock state. In at least majority of them would definitely, become more stable when the balloon is on. So I think people who have used it will vouch for it. I don't think IABP will go out of vogue as a MCS device, even though people project it that way. And clearly in Asia, for sure, given our resource limitations, it would
remain
the first MCS device of choice.
Okay. Now the second question, non-myocardial infarction categories, initiated a VA ECMO. How will you actually choose your LV venting strategies?
Yes. So, okay. My first preference for LV venting strategies, even if it is a non-myocardial infarction, cardiogenic shock. So even if this patient has myocarditis and he's on VA ECMO, my first choice of venting would be IABP. It took a long time for me to convince my cardiologists that these patients do benefit out of IABP, especially in the context of VA ECMO, which is unphysiological. So I'm not looking again here at IABP being LV protective or 28-day mortality protective. I'm looking at unventing the LV immediately when the ECMO is on. So as long as the ECMO is on, I still use IABP as my first MCS.
Which is probably realistic, real world possible, because when we add IABP to a ECMO, with the Indian context or Asian context, the possibility of acceptance to those combination will be maximum because it doesn't add much of the cost. As you said, we presumptively do it at a start of a VA ECMO using IABP. So that's your first choice.
Yes. Once the patient is on IABP and on ECMO, we end up doing quite a lot of echoes during the course. And a few things that get assessed would be the LV dimensions, the aortic valve openings, and the aortic VTI. The drop in aortic VTI early in MI or even non-MI is a clear sign that the LV is tiring out. Probably the afterload from the ECMO is also not helping. And once it reaches a stage where the aortic valve is intermittently opening, we then switch over from IABP to Impella. So our second choice would be Impella in this context. And I'm only talking about...
Is Impella again for any form of myocarditis, including biventricular failure?
Yes, yes. So for if aortic valve is only opening intermittently, despite IABP in situ, the next choice would be to remove that IABP and insert an Impella so that it gets unloaded properly.
So LV unloading happens.
LV unloading happens properly. So Impella here gets used only as an unloading device, not as a LV support device or a ventricular assist device. It gets put in only as a unloading device, which means we run it at P1 or P2, maximum P3, and clearly make sure that the LV unloading definitely happens. LV doesn't distend. The challenges of using Impella along with ECMO is Impella uses an axial pump.
Hemolysis.
Yeah, it's really horrible. You'll get to see hemolysis invariably. The second challenge, technical challenge that we usually see is the catheter tends to slip out.
Position.
Yeah.
Yes,
Now,
yes.
the Impella catheter tends to slip out of the LV. And it's very common that this happens, and we need to keep vigilance while we use these advanced devices.
So there is a question, I think there is a confusion that Impella and IABP can't be used simultaneously. You said pull out the IABP, push a Impella on. If you are
so we use both Impella and IABP. I'm not aware of anybody who uses that.
I think there is I think somebody understood it by that way.
Okay.
Both together, we pull out IABP and we replace it with an
Impella device.
Both are not together.
Yeah.
So roll off. So is there the two options? You never go for any other modalities? Modalities or...
Yeah. So that we were heavily reliant on surgical LV venting till about a couple of years back. One thing we noticed with surgical LV venting is the fact that there was definitive control over the venting side of things. But every time our patient's LV recovered, we realized that when the LV vent comes out, they get some element of stroke. And
Because of the thrombus or clot sitting there?
so after all the hard work you do, your
Okay.
patient is wide awake talking to you with the LV vent on, and they go to the OT and come back, they're hemiplegic or hemiparetic, which we thought, was either related to the cannula or due to the thrombogenicity of or the coagulopathy associated with all this. But all said and done, I'm speaking to a few surgeons. It's probably one of the problems which we faced. A lot of others don't face it. They use specific cannulas for venting LV. Some of them use a J-tipped cannula. The others use cannula that are metal tipped rather than a plastic tipped. So all these finer technical aspects do help you at that point when you're using a surgical LV vent.
Charan showed that a lava kind of thing you go through interceptal, sucking both the RA and LA together. Any experience or any?
No. We don't have any experience with lava. In fact, of course, this is probably not in the context of LV unloading. We do PAVA, PAVA, Singapore, where drainage happens through either a Protect Duo.
Okay.
The Protect Duo, the problem with Protect Duo is it's costly, as well as the sizes are quite big for the Asian population. So we now started using the long Medtronic cannula, which goes into the PA. So it gets guided into the PA, and you have your other venous drainage happening from the groin. So return essentially goes into the PA. But when you use PAVA, it will be the other way around. You will drain it from the pulmonary artery and send it back to the femoral artery. Okay.
So how do you monitor the placement of impella? That's one question. Is it echo or is it a fluoroscopy or is it a size, positions given, marking given at the periphery?
Yeah, so the insertion of impella is done by the cardiologist in our center. It's done under fluoroscopy. Yeah, and subsequent management happens in ICU, where our patients are serially monitored on 4-hourly echoes, specifically looking for the tip of impella. That is about the position of impella. And I think that's the one thing which really hits you hard. When the positions change, the alarms go, and your LV venting is not good enough. The other few things essentially, are anticoagulation related. So we don't use heparin for impella, and we don't give it through dextrose. We use bicarb based fluid for impella. What do you call it? I keep forgetting the name. That infusion. And the second thing is we monitor for limb ischemia on the impella limb, as well as we do look out for other complications of impella. So
lysis and other complications.
Yeah.
So the last two questions, sir. One is related to ECPRs. So when do you actually attempt for LV venting in a ECPR situation?
I think that question was directed to me because probably of the recent paper that we published. Yes. Now, ECPR, it's definitely a different ball game, but you would think that given the amount of myocardial stunning and the amount of LV dysfunction that ensues CPR, these patients would benefit out of a venting device or an unloading device. We were using it very regularly. Even now, some of our patients do get it. But what got us very curious about this unloading in ECPR was a nice paper from Munich, where Devathasan and his colleagues, in a series of patients, he did a propensity match study to show that LV unloading in ECPR is very important. Not only did he do that, he compiled literature to show that whenever you use LV unloading in ECPR, the outcomes have been good.
Okay.
That clearly aroused our curiosity, and we went to the ELSO registry to do what is called as a target trial emulation. Now, a target trial emulation is essentially an RCT of the observational data. So you have observational data where you would have had, the ELSO registry will have a mix of patients who would have had LV unloading after ECPR and no LV unloading after ECPR.
Okay.
So we basically propensity match them so that both groups are equal, and then apply the same criteria of RCT and find out whether it is really working or not. So it's a novel technique, and it's getting more and more used in critical care settings. And when we did that, we figured out that LV unloading is probably not helpful in ECPR. We did apply criteria of arrest, criteria of Prague HCA trial, as well as the Inception trial to these cohort of ELSO registry patients. And we found out that the results were more or less uniform. So from a literature perspective, I believe this is very dubious. The results are quite
Any hypothesis behind this?
Yeah, trustworthy. But then the fact here is it doesn't work for some reason. And one of the things which we postulated might be happening in the context of ECPR. I'm sure, Venkat, you would have seen this when patients go on ECMO after CPR. Within 24 to 48 hours, they go through a period of severe vasodilatation, a massive source response, and they rather than just a cardiogenic shock, you will be dealing with a mixed shock, which is predominantly distributive. And this happens as a sequelae to all patients who get cardiac arrest. So there's probably a body mechanism whereby it goes into vasodilatation and you don't need to unload in a big way. But I'm not sure what exactly the reason is. At least the results were quite perplexing for us when we figured out that this doesn't work with ECPR. I mean, you could have other postulates to explain maybe.
Very interesting discussion. We are coming to a last part of it. The question is, okay, we unloaded. When do you revert back that unloading? Before just cannulation, you give an unloading, stop the unloading for some time and see how the LV is working. What is the timing of, again, withdrawal of this unloading?
Yeah. So we keep it simple. So whether if it is going to be IABP or Impella that's being used for unloading, we just keep those devices in situ, come off ECMO. The standard criteria for coming off ECMO applies. And we make sure that the patient, if he's on an Impella, the right heart is not dysfunctional and he should be able to, the Impella should be able to support the left heart well. The same thing applies for IABP as well. The problem comes with unloading when your LV doesn't recover. And how do you find that out? It's sometimes tough. But then what we do on a general basis, say the patient is on an IABP, we cut down or we pause the IABP when we do the echocardiogram, and then we look at the aortic VTI serially, and then again restart the IABP as part of it, just to figure out how much the LV has recovered, and then once the aortic VTI is at expected levels, say more than 11 or 12 meter per second, you end up weaning off ECMO. If in that process we need to add some inotropes, a moderate dose of inotropes is always welcome, and we just try to come off ECMO first.
Okay. Charan, you have been listening and being involved in any questions to sir?
No, sir,
interaction.
it was a very comprehensive discussion. So I think we have discussed all the burning questions which actually involve
A lot of interaction, lot of questions. I think I
the
tried
EV
to
unloading.
summarize. And a wonderful experience once again, sir. Thank you very much. Simplified to the core, learned a lot of clarity. Amazing experience, sir. Thank you so much for being with us.
No worries. Thanks. It was a pleasure.
So we will keep learning and probably keep meeting, sir, so that we come out with same. I do understand most of us do find these queries and debates keep going on.
Yeah.
And, yes, that paper triggered us similarly, and most of us in those situations, maybe LV gets into a back seat because initially it's all about keeping some circulation on, keep the brain on, and see next few hours how things goes.
Yeah.
Thank you very much, sir. Thank you, Sharon, for being with us and bringing this topic, and we continue to bring this series. And I thank all the audience who have been actively participating. And this program, which I was telling you, sir, every alternative week, which we bring some of the ECMO programs and alternative programs, keep on this both YouTube and Facebook and our ESOI group, so that the recorded videos gone through almost 5 to 10,000 viewers in a couple of days. So it reaches to a wider audience for their learning and for their exposure, sir. Thank you very much for being a part of it.
No problem.
All the audience.
Yeah.
And I conclude the session. Thank you.
Thank you.
Thank you.
So much.